Our topic of discussion today is male infertility. So first of all, we are going to have a overview about the topic infertility. So what do you mean by infertility? How do you define infertility? So infertility, the definition is inability of a couple to conceive even after even after regular unprotected sexual intercourse for 1 year. But it is said that if the age of the female is more than or equal to 35 years, and even after trying for a period of 6 months, if the couple is not able to, if the female is not able to conceive, even after trying to conceive for a period of 6 months, then you can start treatment. So, by definition, it is the inability of a couple to conceive even after regular unprotected sexual intercourse for a period of 1 year. So, but if the age of the female is more than or equal to 35 years, even after 6 months of trying to conceive, the female is not getting pregnant, you can start a treatment for infertility. Now, what is the incidence of infertility? Incidence is 10 to 15%. So, and there are two terms which are important. What is fecundability and what is fecundity? So, fecundability is the ability of a female to conceive within a menstrual cycle. Ability of a female to conceive within a menstrual cycle. So, what is fecundity? There is a slight difference. That is the ability of a female to give live birth in a menstrual cycle. So that is the difference between fecundability and also fecundity. Now we are going into detail about the causes of infertility. So there are different reasons for a couple to be infertile. These are the causes of infertility. So there can be male causes of infertility, there can be female causes of infertility, and there can be some unexplained causes of infertility. Out of which the male causes of infertility, that comes to around 40% of causes of infertility, and the female causes of infertility, it is slightly more, that is it comes around 40 to 50%, and there are some causes which comes unexplained, so that contributes to around 10%. So that is all about the causes of infertility. Now we go into detail about the male infertility. That is male infertility. That is our topic of discussion today. That is male infertility. So before that, there is a question. Whenever there is a couple who is trying to come to you with the inability to conceive and you are suspecting infertility, the first investigation that is to be done in an infertile couple, that is semen analysis. The answer is semen analysis. This is the first investigation that should be done in a infertile couple. So, we are discussing in detail about the semen analysis. Some important points regarding this. In order to take a sample for semen analysis, what kind of a sample, how do you take the sample? By the masturbation. You take the sample by masturbation. So, before taking the samples, it is compulsory that the male should have a period of abstinence, that is 2 to 7 days abstinence is required before taking the sample for semen analysis, and they should take care that it should not be taken in a latex condom. It should not be taken in a latex condom. And after taking the sample, the study is done on the liquefied semen only, and the liquefaction time for the semen is equal to 20 to 30 minutes. And after collection, it should reach the lab. Okay, after collection, it should reach the lab within what time? Within 60 minutes. This is very important. After collection, this sample should reach the lab within 60 minutes. And if you get an abnormal report in the semen analysis in the first time you are getting an abnormal report, before starting treatment, you should have a repeat semen analysis, and repeat semen analysis should be done at least 1 month apart. So it should be done at least 1 month apart. You should have a repeat semen analysis before taking treatment. So before discussing the semen analysis in detail, we have to discuss about the hormonal support of a spermatogenesis. That is how the sperm is being produced. Spermatogenesis. What is the hormonal support of a spermatogenesis? So spermatogenesis, we know that there is a higher center in the brain which is controlling the process of spermatogenesis. So this is the higher center in the brain. So in the brain, you have first the hypothalamus. So hypothalamus, that is producing gonadotrophin releasing hormone, and it is acting in the anterior pituitary, and from the anterior pituitary you are getting two hormones here, that is the luteinizing hormone, that is LH, and follicular stimulating hormone, that is FSH. So this FSH and LH, this will be acting further on the testis. You have the testis here. So this is the testis. And testis, you have two types of cells, that is Leydig cells and Sertoli cells. And we know that the LH will be acting on the Leydig cells and FSH will be acting on the Sertoli cells. So LH acting on the Leydig cells, it helps in the production of an important male hormone, that is testosterone. Okay. So testosterone, it is an important hormone for the, it is stimulating the process of spermatogenesis. And we know that this testosterone is having a negative feedback on the LH as well as the GnRH. So whenever the level of testosterone is high, it will be having a negative feedback on the LH and also the GnRH. Now what about FSH? It is acting on the Sertoli cells, and it will produce inhibin from here. Inhibin, this is a hormone produced, and it will be having a negative feedback on the FSH. So indirectly, LH, FSH and testosterone, all this will be stimulating the process of spermatogenesis. However, the important hormone which is stimulating or helping in the spermatogenesis is the testosterone. Okay. And next we will be discussing about the sperm pathway. So this is very important if you are going to discuss about the obstructive azoospermia in males, which is an important cause of infertility. So first we'll discuss about the sperm pathway here. So we know that there is a testis here. So this is a testis. The sperms are formed here by the process of spermatogenesis. Now we have an important structure here. So what is this? This is a testis. Both sides you have, no? And you have epididymis here. The sperms are attaining maturity and motility here, that is in the epididymis. Now I'm going to discuss other structure, that is the important pathway for the sperms. That is, this is the vas deferens, okay? Vas deferens on either side. Now it is joined by another structure, that is a seminal vesicle. Sorry. On both sides it is joined by the seminal vesicle. So this is a seminal vesicle. Now the structure which I am drawing, here you have the bladder, urethra it is coming here, on either side you have the prostate here. So this important structure which is also contributing to the semen, that is the prostate. This is prostate. So this is the pathway of the sperm, that is the sperm which is coming from the testis. It attains maturity and motility in the epididymis. So this is the epididymis. Then it comes into the vas deferens, and it is joined by the secretions from the seminal vesicles, which contributes majority of the volume of the semen. That is seminal vesicle, which is very important because it contributes majority to the volume of the semen, and it contributes fructose to the semen. So after joining with the seminal vesicle, this tube is called ejaculatory duct. After joining with the seminal vesicles, the vas deferens is called ejaculatory duct. Okay, ejaculatory duct. Now after this, the prostate is also pouring some secretions into the semen. Then it comes, that is downwards. Then it is at last, during the process of sexual intercourse, the bulbourethral glands will be giving some secretions into the semen. This happens only during the process of intercourse. That is the bulbourethral glands. So what is the sperm pathway? It is from the testis to the epididymis, then the vas deferens. It is joined with the seminal vesicles and ejaculatory duct, and the prostate gives some secretions. At last it comes out. Then at the time of sexual intercourse, the bulbourethral glands also give some secretions. That is the sperm pathway. So roughly, if I am drawing all the pathway here, you have the hypothalamus here. hypothalamus will be releasing gonadotrophin releasing hormone, and it will be acting on the anterior pituitary, and it will be producing FSH and LH. It will be acting FSH and LH. It is acting on the FSH acting on the Sertoli cells. It is acting on the Leydig cells. Okay, helping in the process Leydig cells. Testosterone is produced from the Leydig cells, and further it helps in the process of spermatogenesis. So this much takes place in the testis. Okay, from the testis it is going into the epididymis. So in the epididymis, that is the caudal end of the epididymis, is the site at which the sperms are attaining the maturity and motility. At the caudal end of the epididymis, the sperms attain maturity and motility. So from the epididymis, we have the vas deferens, and from the vas deferens to the vas deferens, the seminal vesicle is also pouring the secretion, that is seminal vesicle, and it becomes, this is called, after joined by the seminal vesicle, this is called ejaculatory duct, and after forming ejaculatory duct, the prostate will also be giving some secretion. Okay, so the pathway is testis, epididymis, vas deferens, sorry, it is joined by the seminal vesicle. After joined by the seminal vesicle, this is called ejaculatory duct, and the prostate will also contribute to secretions. This is prostate. At last, the bulbourethral glands this gives secretion at the time of intercourse. So this is an important sperm pathway here. Testis, epididymis, vas deferens, ejaculatory duct. It is joined by the prostatic secretions and bulbourethral glands giving secretion at the time of intercourse only. Now we are going to discuss in detail about the semen analysis. So we are discussing about the WHO 2010 parameters of a normal semen analysis. So as per this, we are giving the normal lower limit of the normal for each of this parameter. So what is the normal volume of the semen according to WHO 2010 parameters of the normal level? That is, that volume should be more than 1.5 ml. Okay, that is the volume. And what about the pH? The pH of the semen should be more than 7.2. And third one, about the sperm concentration, is very important. Sperm concentration, we are out of 1 ml, it should be more than 15 million. That is 15 million per ml. That is a sperm concentration. And what is a sperm count? Normal sperm count. That is out of one ejaculate. That is per ejaculate. What is a normal sperm count? It should be more than or equal to 39 million sperms per ejaculate. And what is the average sperm count? Average sperm count, it is between 60 to 100 million per ejaculate. That is the average sperm count. Okay. And what about the sperm morphology? So the morphologically normal sperm should contribute, that is more than 4% of the sperm should be of normal morphology. And sixth one, about the sperm mortality, that is total mortality should be, it should be more than 40%, out of which the progressive forward mortality should be present. Progressive forward mortality should be more than 32%. So, and viable sperms should be more than 58%. That is, viability should be more than 58%. And in this semen, the WBC count should be less than 1 million per ml. It should be less than 1 billion per ml. So if there is an infection in the male genital tract, the drug of choice is doxycycline. Now we have discussed about the WBC count. Now the total number of round cells. Round cells, it includes WBC as well as globular sperms. And its count should be less than 5 million per ml. So what is the difference between non-motile viable sperms and the dead sperm? So there is a test which is used to differentiate between the non-motile viable sperm and the dead sperm. That test is known as hypoosmotic swelling test. Hypoosmotic swelling test. So this test is able to differentiate between a non-motile viable sperm and a dead sperm. So what happens? The osmosis is occurring only in non-motile viable sperm. That is, as it is a viable sperm, the osmosis is able to take place in the viable sperm only, whereas this does not take place in a dead sperm. So it differentiates between the two. So, what is the importance in differentiating between a dead sperm and a non-motile viable sperm? Because we can use this non-motile viable sperm in a process, that is, it can be used in intracytoplasmic sperm injection. So, intracytoplasmic sperm injection. So, this can be used in the process of ICSI. That is the importance to differentiate between the two. Now, we are going to discuss about the abnormal semen analysis. Some important terms are we going to discuss here. So, if there is no semen, this is called aspermia. And if the concentration, sperm concentration, it is below, that normal is more than 15 million per ml. If it is less than 15 million per ml, it is called oligospermia. And if this count or concentration is below 5 million per ml, it is very low. That is, it is severe oligospermia. Okay. And if the motility of the sperm, that is, if the non-motile sperm is present, something, a term which is related to motility, that is called asthenospermia. Asthenospermia, the sperms are not motile here. That is, there is a decreased motility. So, if the sperms are of abnormal morphology, with abnormal morphology, it is called teretospermia. Teretospermia means the sperms are of abnormal morphology. So if you are seeing non-viable sperms or dead sperms, non-viable or dead sperms, the term used is necrozoospermia. Sorry, necrozoospermia. That means non-viable or dead sperms are present here. So, what is the term which is used for the presence of or increased WBCs in the semen? If you see an increased count of WBC, the term which is used is leukocytospermia. So, these are the some terms which are used in abnormal semen analysis. You have to be very familiar with this. So, an important abnormality I'm going to discuss about in detail is the azoospermia. So what is azoospermia? It means there is absence of sperms in the semen. If the semen itself is absent, it is called aspermia. If the sperms are absent, it is called azoospermia. Azoospermia means absence of sperms in the semen. So there can be different causes. So we have learned that hypothalamus and pituitary, that is the higher center, that is controlling the process of spermatogenesis at the testicular level, testis, and testis, it is followed by a post-testicular pathway for the sperms. Okay, so this azoospermia or absence of sperm in the semen can be due to problems at these three levels. So it can be a problem at the higher center like hypothalamus and pituitary, that is one cause. It can be a problem occurring in the spermatogenesis at the testicular level, that is a second cause. Or it can be due to a defect in the or obstruction in the pathway at the post-testicular level, that is called a post-testicular cause. Post-testicular cause is also known as obstructive azoospermia because it can be due to an obstruction in the sperm pathway. So it is called obstructive azoospermia. We are going to discuss about each cause in detail. So we are going to divide this into three causes. That is the pre-testicular level. There is a testicular problem, or it can be a post-testicular. Post-testicular usually it is an obstructive problem. Obstructive azoospermia. Okay. Sperm pathway is defective. So these are the three causes of azoospermia. So pre-testicular means the problem is in the hypothalamus or anterior pituitary. Anterior pituitary. So we know that the hypothalamus, it will be producing GnRH, and GnRH is stimulating the anterior pituitary to release the LH and FSH. So whenever there is a problem in the hypothalamus or pituitary, what will be the level of these hormones? That is LH will be, LH will be decreased, FSH level will be decreased. We know that LH will be stimulating the Leydig cells and producing the testosterone. So as LH is decreased, the testosterone level also goes down. So in a pre-testicular cause or a hypothalamus or pituitary cause, or the levels of all these three hormones, that is LH, FSH and testosterone, all three will be decreased here. That is a very important point. That is in a pre-testicular cause of azoospermia, the LH, FSH and testosterone will be decreased. What happens in a testicular cause? Testicular cause means that the problem is in the testis. Testis is in problem. So the level of testosterone, it is less, it is decreased. So we know that the testosterone is having a negative feedback on the LH and FSH. So as the level of testosterone is decreased, the LH level increases and FSH level also increase. So in a testicular cause of azoospermia, testosterone goes down whereas LH and FSH high. So in the post-testicular cause, there can be a defect in the sperm pathway. Sperm pathway means after the testes, we know that the pathway is like epididymis, vas deferens, ejaculatory duct. It goes like that. Okay. So as it is a defect in the sperm pathway, it has nothing to do with the hormone. So the level of LH, FSH, and testosterone, all these are normal here. All these are normal here. So if you are getting an abnormal semen analysis and in that you are getting an azoospermia, that is there is an absence of the sperms, the next test you can do is the levels of LH, FSH and testosterone, because that will give you that an idea to differentiate between the pre-testicular, testicular and post-testicular causes. Because if the LH, FSH comes down and testosterone also comes down, all this comes down, it can be hypothalamus or pituitary cause. Or if the testosterone comes down and LH and FSH increases, it is a testicular cause. If the level of all these hormones are high, we can definitely suspect an obstructive azoospermia or a post-testicular cause of azoospermia. Okay, now I am going to discuss in detail about the obstructive azoospermia. Obstructive is a post-testicular cause of azoospermia. For discussing the obstetric azoospermia, we have to be very thorough about the post-testicular pathway. So, from the testes, sperms are being produced, and we know that at the caudal end of the epididymis, the sperms are attaining the maturity and motility here. So, the next one is the epididymis. So, another important tube here, that is the vas deferens. Okay, so this is the vas deferens, and it is joined by the seminal vesicle. So this is the seminal vesicle. So what is the importance of the seminal vesicles? It is contributing majority of the seminal volume, and also it gives fructose to the semen. And after being joined by the seminal vesicles, this is called ejaculatory duct. That is an important structure here. That is the prostate. There is a bulbourethral glands here, which is giving secretion only at the time of intercourse. So the important structures are testis, epididymis, vas deferens, seminal vesicle, ejaculatory duct, prostate is here. This is the prostate. Okay, prostate. This orange color structure, that is the prostate. Now we are going to discuss about the block here. Block in the sperm pathway. What happens? There is a block in the sperm pathway. So see the structures here: testis, epididymis, vas deferens, seminal vesicle, ejaculatory duct, prostate. So this is how the pathway goes. Now we are going to see the obstruction at various levels. Okay. So there can be a block in the pathway above the level of seminal vesicle. So this is the first level of the block, that is A. So A is a block above the seminal vesicle. So if there is a block in the seminal vesicles, can you get sperms? No, the sperms are absent here. Sperms are absent here. So, but the fluid from the seminal vesicle is able to go down. Okay, so the fluid from the seminal vesicle is adequate. Fluid from the seminal vesicle is present. So, as we know that this fluid from the seminal vesicle is contributing to the majority of the volume of the semen. The volume of the semen is adequate here. Volume is adequate or normal here. So we know that the seminal vesicle is also contributing to the fructose in the semen. So fructose is also present in the semen. And besides that, the bulbourethral, so here you have the bulbourethral glands and the prostate here. So the prostatic secretions are also present here, and bulbourethral gland secretions are also present here. So whenever there is a block above the level of seminal vesicle, the fructose is present in the semen, and also the fluid volume of the semen is also adequate. That is, volume is normal or adequate. So now we can have a block below the level of a seminal vesicle. That is, the block is at this level, that is below the level of seminal vesicle. That is B. B is block below seminal vesicle. So what happens when there is a block below the level of seminal vesicles? Sperms, what about sperms? Sperms are absent here also. Azoospermia is present. And what happens when there is a block below the level of seminal vesicle? The seminal vesicle is not able to add its secretions into the semen. And because of that, the volume of the semen is very less. That is, volume is poor volume of the semen is there. And the seminal vesicle contributes to the fructose. So fructose is absent here in the semen. Fructose is absent. That is absent. That is a very important point. If there is a block below the level of the seminal vesicle, the fructose is absent in the semen. And what about the prostatic fluid and also bulbourethral secretions? Both these are present. Prostatic fluid and bulbourethral secretions are present. So the important differences between the block above the level of seminal vesicle and below the level of seminal vesicle is that when there is a block below the level of seminal vesicles, how can you know that the fructose is absent and the volume of the semen is very poor? That is the main difference. So the important point to be known is, from the exam point of view, if fructose is present in the semen, it indicates a block above seminal vesicle. So the investigation you have to do in this case is a scrotal ultrasound to look at to identify the level of the obstruction. So what happens? How to proceed if the fructose is absent in the semen? That means a block below the level of seminal vesicle. So it can be a block in the ejaculatory duct, because after being joined by the seminal vesicle, vas deferens is being joined by the seminal vesicle to form the ejaculatory duct. So there can be a block in the ejaculatory duct. So in order to identify this block, we have to do a transrectal ultrasound. So, and if the fructose is absent in the semen, it can be due to bilateral absence of bilateral absence of seminal vesicle, or plus it can be usually associated with the bilateral absence of vas deferens. So this condition is seen in a autosomal recessive disease called cystic fibrosis. So you have to screen for this disease. You have to test CFTR gene testing. So that is all about the obstetric azoospermia. Then how can you manage? So we are discussing about the management of obstructive azoospermia. So we know that in a case of obstructive azoospermia, testis is normal here. Only the post-testicular pathway is affected. So there can be normal sperms which are present in the testis or the epidermis. Okay. So how can you proceed to the treatment? We can aspirate or extract the sperms from the testis and epidermis. So if you do it from the testis, there can be two procedures, that is TESSA and TESSI. TESSA means testicular sperm aspiration. Testicular sperm aspiration, or you can do a testicular sperm expression, sperm extraction. Because normal sperms are present at the testis, and the problem is it in the post-testicular sperm pathway and epidermis. Two procedures are there, that is percutaneous epidermal sperm aspiration and also microsurgical epidermal sperm aspiration. Both of these are aspiration. This is percutaneous epidermal sperm aspiration. This is microsurgical epidermal sperm aspiration. So the sperms are extracted or aspirated like this, and it is followed by ICSI, that is intracytoplasmic sperm injection. That is how you are managing a case of obstetric azoospermia. We have to find out the cause. Then you can extract the normal sperms from the testis and epidermis, and it can be injected into the ovum by intracytoplasmic sperm injection. Then how do you manage other causes of male infertility? Management of male infertility, other causes besides the obstructive azoospermia. How do we manage other causes of male infertility? So if how do we manage oligospermia, that is oligospermia, where the count is below 15 million per ml, but it is between 10 to 15 million per ml. So you can proceed with an intrauterine insemination, IUI, that is intrauterine insemination. So if the sperm count is below 15 ml, 15 million per ml, but it is above 10 million per ml, we can use an intrauterine insemination procedure. But there is oligospermia and the count is between 5 to 10, that it becomes below 10, 5 to 10 million per ml, we can do an in vitro fertilization here. And when there is a severe oligospermia, that is the count comes below 5 million per ml, there is no option other than the intracytoplasmic sperm injection. Directly inject the sperm into the ovum. So that is, and we have discussed the treatment of obstetric azoospermia. In obstetric azoospermia, the problem is within the post-testicular pathway. So there can be normal sperms which are present in the testis and epidermis. We have to aspirate or extract the normal sperms and inject it into the ovum by an intracytoplasmic sperm injection. Now we have the asthenospermia. Asthenospermia means the sperm motility is affected. There are sperms with abnormal motility, no motility is present. So in that case also, intracytoplasmic sperm injection was the option. So that is all about the male infertility, the causes of male infertility and the treatment of different causes of male infertility.